So thank you, Dr. Skeen Singh, for giving me this opportunity, and other panelists. Good evening, everybody, and good evening, attendees, for coming in at a little late hour. So my presentation is on scleral fixation in an Aniridia.
I requested the other person to start after him.
My presentation is on scleral fixation in an Aniridia eye, and I'll be presenting a couple of videos of Aniridia IOLs being scleral fixated in these post-traumatic eyes. So I have no financial disclosures to make. I'm working in Ludhiana at Advanced Center for Eyes. As you all know, penetrating ocular trauma frequently causes combined lens and iris tissue damage, resulting in traumatic cataract, corneal irregularities, traumatic aniridia, which may be complete or partial with loss of lens iris diaphragm function. And the management of these patients with coexisting traumatic iris deficiency and cataract is often very challenging due to the complexity and various associated other ocular pathologies. Chief complaints in these patients are usually photophobia, cosmetic defect, impaired vision, and depth of focus loss. And the options which we can technically use in these patients is either to use iris diaphragm lenses or segmental prosthetic iris devices, flexible iris prosthesis, tinted or painted contact lenses over a intraocular lens later on, or we can always use an Aniridia intraocular lens, which is a very good option in these situations. So I'll be presenting two of these cases which are managed with the Aniridia intraocular lens implantation. First video this is one of my cases. He came with a trauma, and I did the primary repair. This patient was done almost more than 10 years back, and he had a very long follow-up of almost 6 years. And he, in fact, achieved a visual acuity of 6/6 with glasses, although he had secondary glaucoma later on after a few years, which was managed medically. So this is the first case. You can see the corneal sutures. When I did this surgery, I was using 20 gauge vitrectomy system. So we have placed a 6 millimeter infusion cannula at 3 millimeter away from the limbus or in the pars plana. This is to maintain a steady intraocular pressure throughout the surgery. A large conjunctival flap is made, and hemostasis is achieved. A scleral or a sclerocorneal tunnel is fashioned, groove is fashioned of about 10 millimeters to accommodate this large lens, and triangular scleral flaps are made to stitch these sutures. Anterior chamber is opened. Partial vitrectomy was already done in this situation, and there was a total aniridia, so there was no need for any further anterior vitrectomy to be done. In this case, I used a 10-0 polypropylene suture. Nowadays, I am using 9-0 polypropylene, and this is the lens from a company called Oftec in Holland. So these are basically custom-made Aniridia lenses, and it has worked very well in our hands. Actually, in even last 10 years, it has not even given off any color or anything. This is and it gives very good cosmetic appearance as well as the intraocular correction. So the scleral sutures are being tied under the flaps. you can see a lot of aggression of fluid, but the intraocular pressure is maintained because there is a continuous flow of fluid from the pars plana cannula. So then the large wound again needs to be sutured with a 10-0 polypropylene. And these are the sutures of previous surgery, because he had a trauma with a large wound, and the whole of the lens and the iris diaphragm was pushed out. So we have used sutures in this surgery, and this is the post-operative photograph after 10 days of surgery, and this is 5 weeks after surgery, where he had a visual acuity of 6/6 with -2.5 cylinder at 95 degrees. So this is a follow-up photograph, almost 5 years and 9 months down the line, when he still maintained a visual acuity of 6/6. Another video is with the surgery done more than 5 years back, although he did not come for follow-up after a few months. He also achieved a visual acuity of 6/12 with glasses, and intraocular pressure at that time was normal. So this surgery was done elsewhere. He had a corneal scar. We fashioned the scleral flaps, and a corneal groove 10 millimeter was made. And in this surgery, we have used a 23 gauge trocar cannula system. And we have done anterior vitrectomy as well. Then the anterior chamber was entered, the incision was enlarged. The 9-0 suture was used in this situation. 9-0 polypropylene was used. The suture ends were brought out, and in this case, the person asked for a black colored Aniridia lens, which was specially ordered and custom made for the patient. It takes about a couple of months to deliver, but at the end, it gives a good cosmetic result as well as the intraocular result. So same way, the lens, this is a PMMA kind of lens, because Aniridia lenses are large lenses. You need a large incision and fixation. So similarly, the polypropylene suture is buried under the scleral flaps. On both sides. And the corneal wound is stitched with 10-0 polyamide. Again, we have not used glue or sutureless fixation here. And the intraocular pressure is maintained throughout the surgery because of the pars plana cannula. Pars plana cannula is inserted at the beginning of the surgery and removed at the end. And the conjunctiva is stitched. So this is the first post-op day photograph, and 2 weeks visual acuity was 5/60, which later improved to 6/12 with correction. So in Aniridia IOL fixation, pars plana cannula is a very important part. It is placed in the beginning of the surgery and maintains a steady IOP. at least 10 millimeter sclerocorneal incision is given. And the triangular partial thickness scleral flaps are made for suturing of these stitches, and pars plana cannula, of course, is maintained throughout and removed as a last step of surgery. So to conclude, restoration of normal vision and good cosmesis after surgery as severe as leading to complete aniridia and traumatic cataract, although not unique, is very surprising. And Aniridia IOL is a very beneficial therapeutic option for achieving mechanical, physiological, optical, as well as cosmetic success in these eyes with coexisting aniridia and cataract. Thanks for your patient hearing.
A wonderful presentation. So as you have already mentioned, the large size of the IOL would require a bigger incision size. So is the secondary glaucoma, and I believe the astigmatism too. So we need to be very careful about the astigmatism.
Yes.
And do you recommend the tunnel or the limbal incision for these patients?
How do you get to the information?
We go as far as possible towards the sclera, but because it is a very large incision, tunnel of course can be made, but that tunnel also will have to be at least 8 to 10 millimeters. If 8 millimeter tunnel will probably fit in 9 or 10 millimeter IOL. So sometimes you don't want to take a chance because these are custom made lenses and you don't have any backups. So I would recommend this, and this works well in my hands. But of course, that's probably a personal preference.
Though endothelial is a big challenge in all these patients, but I believe with the scleral fixation, aniridia lens would be more contributed to this jet damage. We need to follow these patients more closely for the endothelial cell count also.
Definitely. This aniridia in itself can cause secondary glaucoma.
Yeah.
And of course endothelial loss. But as I said, a steady maintenance of intraocular pressure decreases the intraoperative, at least, loss of endothelial cells. It will not completely remove that chance, but at least that softening or folding of corneal tissue is not there when you have a continuous flow of intraocular fluid.
Dr. Dinesh, there's another issue which I wish to discuss with you. Like, these are mostly the post-traumatic patients. So
yes, sir.
Is there any patient you have seen which has gone in hypotony, low pressure, post-implant? Or I would be more precise, ciliary shutdown?
Not these patients. If you have done a good anterior vitrectomy, then that membrane formation all over the ciliary body will not be there.
Okay.
But if you have not done a good vitrectomy and there is fibrosis around that ciliary body, because sometimes what happens is that we see hypotony and we feel that this eye is not going to behave well, and we don't take it up for surgery. But we have seen when you take up these surgeries, take up these eyes and do a good membrane removal, anterior membrane removal along with synoculosis, as well as a good anterior vitrectomy. The functional results as well as cosmetic results are sometimes very gratifying. Although trauma eyes, as you have said, they are for long-term follow-up, and anything can happen even over a longer follow-up. These eyes are even prone to detachments later on and other things, because even they have had at least 1 or 2 surgeries before we take them up for this kind of a situation. So these are not plain and simple fresh eyes where you have done this surgery.
So to sum up, we need to be very careful for customized planning of the surgery, incision
Definitely.
site, glaucoma, frequent follow-up, more closer follow-up, and
Sure,
endothelial cell count more frequently.
Yes.
you,
Even for congenital cataracts and even for, in fact, a trauma eye, even a blunt trauma, the chances of glaucoma are going to be there for umpteen number of years. Maybe they need a follow-up throughout their life. Angle
Yeah,
recession
exactly.
might angle recession might present few years down the line.
Exactly.
Yeah.
Thank you, Dr. Dinesh, for a wonderful presentation.